Hello. Good evening, everyone. Very nice to see you all this evening, and welcome to our webinar series on infectious disease diagnostics. A very, very warm welcome to everyone here, our panelists, and our valued attendees. Today, our webinar will cover the topic of current day challenges in infectious disease diagnostics. So this is actually a very, very real challenge that people across the field face every day. And what we see as a challenge is actually the interpretation of that is different for everyone across the healthcare spectrum. So what we wanted to do today was discuss when a doctor orders a test, what are the challenges and questions in their mind? When a test is actually executed, are there challenges in the choice of the test? Are there challenges in the performance of the test? Also, when you get the result, are there challenges in how you view and interpret that test? Because at the end of the day, it is not just a test. It is a test that will have an implication in a patient. On this note, I would like to introduce our esteemed panel who are very, very well familiar with these kind of scenarios, who will take us through the talks of today. Introducing first Dr. Mahua. Dr. Mahua is the Director of Medical Affairs. She has seen both sides of the table, being a doctor, a medical microbiologist, and has extensive experience as a consultant microbiologist, as well as has a passion and a very deep understanding of antimicrobial stewardship and hospital infection control. Next, we have Dr. Chaitali Nikam, Director of Infection. She has a very wide range of expertise across the diagnostic testing spectrum, particularly in infectious disease diagnostics. She's a member of the National Technical Working Group on Private Provider Engagement under NACP. She has worked across several different programs with the NTEP. She has several different, a plethora of publications actually to her credit. And we look forward to the insights that she brings through this webinar. Now, just a little note on how we will proceed. We will have our two talks by our speakers. This will be followed by a Q&A session. Throughout the talks, if you all have any questions that come up, please feel free to type them out into the chat box. Another little note for our attendees today. At the base of your screen, among the buttons, you will also find a poll button. We have created a short poll which will help us to better modulate our webinars and the upcoming webinars that we set up through the feedback that you all provide. So we look forward to starting this session. Dr. Mahua.
Thank you, Sanjana, for the kind introduction. My screen's visible?
Yes.
Thank you so much. A very good evening to all of you. Heartfelt thanks to all the attendees for sparing their valuable time. What I believe is a cognizance of the challenges that we face. The more we are cognizant of it, it always leads the way to solutions. So I think this is a very, very nice idiom I came across. The solution lies in the problem. So as I speak today, what I'll try to structure it as, I'll start with the burden of infections, the contributing factors, and how these contributing factors have even made diagnostics challenging for us, the hurdles that we face on a day-to-day basis, which will be elaborated by Dr. Chaitali. I'll just touch through it, and specifically, I'll try to highlight one such thing that has come to my notice, which I even struggled with, and which may significantly aid us in acing the problem statement. So infections and antimicrobial resistance, they continue to plague mankind, so much so that they are undisputedly the biggest public threat. And there are very grim premonitions of 10 million and plus 10 billion plus deaths by 2050 if we do not take, if we are not very alert about it. A single pandemic, apart from the lives that it has cost, can result in economic losses up to 10 in trillions of dollars. And the situation is only made worse by the socioeconomic backbone that gets almost broken by it. Now, these emerging and re-emerging infections, they have reached monstrous levels, and they could do so on the crutches of multifactorial environmental and behavioral alterations that have happened. And this is very important because apart from contributing to the brunt of infections, they have also resulted in thwarting our efforts in diagnostics. So, be it the climatic changes, which completely disarrays the seasonal trends at times. It completely changes the vector populations. It crops up unusual infections in previously unthought of geographical locations. If we take the example of Candida auris, a thermotolerant fungi, and how global warming led to its preponderance as one of the predominant healthcare associated fungal in bloodstream infections across the globe. So while climate is wreaking havoc, the anthropomorphic and the demographic behavior, right from urbanizations to changes in the age distribution, longevity, more of prematures, old age, advance of modern medicine, all of this changes the whole spectrum, the waning herd immunities, the changes in the vaccine dynamics and the protection it provides. So it brings a more susceptible population at play. And all of this actually expands the geography in which the host pathogen interaction is more and more. Again, if we look from the pathogen point of view, the way it is evolving, like it has so much of selection pressures, and due to which they have come up with better mechanisms at resistance, sometimes so much so that it becomes very difficult for us to even detect or predict such resistance. Then the escape of the immune surveillance. So all of this, finally, what it results in is it brings up the bar of diagnostic challenges several fold, because the traditionally what we have been trained to and the basic framework on which we base such of our diagnostic um, plethora, that is completely challenged, because if the natural history changes of a disease, if timelines change, if epidemiology changes, then we cannot base our investigation profiles on the past thoughts and mechanisms that were in place. Now, still all across the globe, people are trying to combat it. And by this, what I mean is that stakeholders across the healthcare ecosystem, they're very invested in their commitment towards a common goal. And the goal primarily is a good patient outcome. That is what we all are trying for, be it a clinician, be it the administration of a hospital or a healthcare system, be it the microbiologist, be it the other lab personnel, any specialty. We are all trying for a good patient outcome. We are trying for more judicious use of antibiotics, and we are trying to be better prepared for future pandemics. That is the goal we are all chasing, and we can very palpably see the commitment, be it the sustainable goals, be it all the international organizations, the national organizations, they're all pitted as a force against this drive. For this drive, they're all aced up for it. But then what is very striking is a paper way back in 2013, which had mentioned certain unmet needs in the diagnostic spectrum. And surprisingly, a lot of it still holds true. We are a decade gone by, and we still lack point of care with a reasonably good turnaround time test which can delineate infection versus inflammation. We still lack a very good biomarker for the same, not only to differentiate infection, but also the class of infections. We also fall short of addressing special population cohorts like the pediatric population. They are in dire need of diagnostics. We are still trying our best to have a syndromic approach which is cost effective and which can be democratized as a solution for all the patients. We are still trying to be better at outbreak detection, at pathogen surveillance, and at understanding the drug resistant mechanisms better and trying to detect them better and detect all of this in a very comprehensive manner. So a decade gone by, and still probably we stand there with these unmet needs. Now, while this is a challenge in the diagnostic spectrum, there are certain on-ground challenges which all of us have faced on the day-to-day working in a hospital or in a diagnostic setup or in an academic institute, wherever we have all worked, be it as a clinician, be it as an admin, or be it as the laboratory personnel. Now, today, I can even vouch, because I belong to the R&D segment as well, I can very well feel the woes of the same. And what are these challenges? It could range from the clinician being challenged with the pre-test probability. And if they have to really, when they are looking at symptoms and signs, when they are presented with the critical patients, when there are so many confounding and overlapping clinical features, if they have to come up with a good pre-test probability on the basis of which they will order and test, they need a very good epidemiological snapshot. And that snapshot need not necessarily be confined to his own city or his own hospital. It really needs the person to have the overview on a statewide level, on a nationwide level, even international levels, given the so frequent air travels that are involved, so frequent medical tourism that is coming up. So they really need to understand the geography better. They need to be presented with good data sets so that they have a good screening in place when they are ordering tests. They have to be aided by different disciplines. So centers where there is a lack of a multidisciplinary approach in the form of grand rounds, case discussions, in the understanding or discussion of various laboratory reports in the context of a patient, that becomes very challenging for one specialty to address the problem statement, because at the bedside, it is an enigma they face. And so many mimics of infection that to be able to delineate, it has to be multidisciplinary, where there is a wider intelligence at play. Again, the brunt of having pocket-friendly diagnostic solutions is a concern both at the clinician and the management level. The patient already is quite burned out once they are in the hospital. And with so much, for evidence-based medicine, with so much to select from, with so much of variety and with so many tests to be ordered in order to find out one answer, it really puts a huge pressure on the patient and his family. Coming to the woes of the lab, while the demand is from the clinical side for certain tests, the microbiologist or the laboratory personnel, they are worried about whether they have the necessary infrastructure to even be able to fulfill that demand. So it's quite easy for somebody to ask, I want to get a TB culture done, or I want to see whether there is a fungal infection involved. But for the microbiologist, it means the BSL-3 facility, it means a negative pressure room, it means the necessary equipments. So then again, the resources, the manpower, the skilled technical staff, because microbiology is a lot of skill involved. So any sort of infectious disease diagnostics requires high precision, skilled technological inputs at the pre-analytical and the analytical steps. So all of this, whether available, and then whether available 24/7, there are so many labs which are not functional round the clock and which completely thwarts the efforts then. All of this taken into consideration, when we try to solve all these problem statements, the very question of return on investment comes up. So if I face a patient who has grown and one yeast in the blood culture bottle, do I have the ability to have the identification and sensitivity cards? Because the cards are very costly and they come in packs of 10. So while I may have one such patient in 2 months, it won't justify the ROI for such an investment, which means that I will not have those. and then I fail in diagnosing it early and proper for the patient. So that becomes a hurdle, a challenge. And then coming to the aspect of the R&D, who funds the R&Ds? Our R&Ds, specifically in our country, are quite removed from the healthcare ecosystem. So again, a lack of crosstalk between one who is developing a test and the other who needs the test or is the user of the test. That is lacking. And we need a fast tracking of regulatory guidelines so that we are better able to use what has come up as a solution. Having said all of this, the last points, but which probably are the most important when it finally comes to handing out a report to a patient for his benefit, are the pre-analytical and the post-analytical considerations. I will not elaborate on this because I suppose Dr. Chaitali will be doing so, but they are very important in providing diagnostic accuracy. So these are some of the challenges which I have experienced in my journey so far, both as a clinician, as a microbiologist, and as a person now who is working closely with the scientific team developing tests. These are the diagnostic challenges. Moving from the generic to a more specific concept, this is the last part of my presentation. This was something that really caught my attention because I feel all of us, we need to improvise on this. We need to be better at this, because only by bettering our skills in this component can we evaluate and suggest and choose better diagnostic solutions. And we are the evaluators of the same. We have seen that our clinical counterparts depend hugely, and they have a lot of trust invested in us when it comes to choosing the right test for them and giving the right interpretation. So it's a huge moral responsibility, and this is one of the paths. We will be, I will personally be very happy to share all the resource material that I have gathered while preparing for this presentation. This is one paper that I really request all of you to please go through if you have not already, which is the evidence-based laboratory medicine. And it's an old paper, 2007, but it's very relevant, I feel. Decisions, finally. And here what we are talking about is a clinical decision. Ultimately, every diagnostic, every efforts in a hospital are made towards making decisions in favor of the patient. So those decisions have to be made with the best available evidence so that care is not compromised. And while the base, as you see, does depend upon the performance of the test, the technical performance, it is more nuanced than what it appears superficially. And very importantly, this paper states, and I can't agree more, we need to start thinking like a clinician. So although far removed from the bedside, however, this concept is changing now. People are talking more about clinical microbiologists and infectious disease specialists. So definitely we do go back to the bedside more often than earlier. But what is very important, that we have to start thinking like a clinician. And when they face a patient, they are very concerned for that patient. For them, they want a diagnosis, they want an answer for that particular patient so that they are able to treat it. And when they are reviewing that case, they start with the history. They're very trained to pick up on the vital signs, the symptoms, the physical features, and then they have the epidemiological information if made available to them, and the local antibiogram if provided by the hospital. So all of this gives them an opportunity to clinically evaluate and come up with a differential diagnosis. And when we are talking about a differential diagnosis, what we are meaning is they have a pre-test probability of certain conditions in their mind. And on the basis of that, they are ordering the investigations. Sometimes they order on their own, sometimes they do come to us for relevant suggestions. Now, at the end of it, they want a directed diagnosis. They don't want a generic pathological evaluation. They want a yes or no. So once they have the test results with them, they frame the post-test probability, and which is a combined estimate of the pre-test probability and the test performance. Now, by the test performance, there are many nitty-gritties that go into the proper performance of a test. I will not again speak much in details about this, but all of this put together brings us to a place where we can reasonably rule in or rule out. That is, move from a zone of uncertainty to a zone of certainty for the clinician, so that they are able to diagnose, dispose, or treat. So this makes the framework of a clinical decision support system where reports become actionable. Now, when we talk about such reports, what we want to say is we should be able to address 4 important questions. What is the sensitivity? What is the specificity? What is the positive and the negative predictive value? And what is, if available in that test spectrum, a prognosis or risk stratification? So I'll just give one example. Suppose there is a test which has been sold to us with the promise of a very high sensitivity and specificity. Now, when I apply this test for 2 very different populations with very different prevalences, that is the pre-test probability. So in one population, let's say the prevalence is 50%, while in the other it is just 1%. It totally changes the predictive value of the test. So simply going by the sensitivity or the specificity makes no meaning unless we take the prevalence into account. So these are some of the intricacies which we need to bring to our table. We need to start understanding some of these if we want to choose right, and if we want to interpret right. We need to really understand this very well. And in doing so, we need to be with the clinicians on the same side of the table, starting with framing the right clinical question. So if it is procalcitonin, do I want to use my procalcitonin as a diagnostic test for differentiating infection and inflammation, or do I want to use it for differentiating a bacterial versus a viral infection? Do I want to use for bloodstream infections, or do I want to use it for respiratory tract infections? Do I want to use it as a diagnostic test, or do I want to use it as a prognostic test? Let's take another example, the fungal biomarkers. Are they diagnostic of molds? Let's say the beta-D glucan. Are they diagnostic of molds? If yes, which category of molds? So these are some of the clinical questions that we should be able to frame properly, following which we should be able to do a good literature review. There is abundance when it comes to search of articles. The keywords have to be properly chosen. We should take help and get guidance from good support systems where we are able to pick up the right literature for the right know-how, so that we know correctly about a test. And a very dependable solution are the systematic reviews, the meta-analysis, or the primary studies. If there are clinical trials, we need to understand what makes a good clinical trial. And trust me, this paper gives some standards, the STARS checklist, which mentions how to judge a clinical trial, what are the points basis which we can depend upon a good study, or if we want to design one ourselves, how we should design it so that we identify the pitfalls of bias and avoid those, so that our interpretation is better. Then again, whether we do it ourselves or whether we refer to such literature at the point of the discussion, or the results and the discussion, when they are concluding, when they are giving us the output, the summary is usually in the form of a lot of statistics. If we do not fare well in understanding those figures, those tables, the graphs, so the sensitivity, the specificity, the likelihood ratios, the predictive values, the odds ratio, the pre-test odds, the post-test odds, the ROC curve, the Bayes' theorem, and all of that, if we do not understand, we cannot interpret of what the claim, what it is saying. Is it meaningful and does it work for us? So that we are not driven or carried away with few facts, and so that we are able to better check, we need to have a good know-how of this. All of this done and dusted, we should base our decisions so that the diagnostic challenges are minimized on evidence-based clinical guidelines. There are very good guidelines available. So if we are talking about antimicrobial stewardship, our starting point should be either the CLSI or the UCAST with the guidelines, so that right from the point of how to perform, when to perform, what are the right drugs to choose, what are the right interpretative guidelines, and sharing them with the clinicians. It has no meaning if we give them MICs without breakpoints, if we do not talk to them about inherent resistance, if we do not tell them about the limitations of performing such MICs, that it doesn't work for a few antibiotics, and there are other test methods or gene-based methods that should be taken into consideration. So we need to share those evidences. Then again, if we talk about fungal diagnostics, or when we talk about the fungal management, where diagnostics is a part of management, and then there are other specialties which need to be taken into consideration, so that we are better able to classify and form the clinical decision-making tool. There are guidelines like URTC. For the hospital-acquired infection, we should be very clear, basis those guidelines, that there are very separate set of the diagnostic guidelines and the surveillance guidelines. And there are many differences where the interpretation, or let's say, if, be it for COTI, be it for CLA-BSI, CRBSI. So the surveillance definition is very different from the clinical definition. The management is very different in both the cases. So all these evidence-based clinical guidelines, there has to be frequent upgradation of this knowledge base, and the sharing. The cross-table sharing with the clinicians is very important. It's our responsibility to do so and bring it to them. Then again, apart from falling back on those international guidelines, we should be then in a position, once we have this know-how, frame guidelines for our own center then, because what works internationally may not work for my patient or my population or my epidemiological dynamics. Finally, for whatever we do, whatever test we introduce, whatever methods we do, there has to be a clinical audit, and there is enough scope for such audits even in a laboratory. So these are outcome-based audits, and that is very important. For a time, maybe 5 years back, if we have introduced a test, whether it holds good, whether it is giving me the same value, has any of the dynamics changed? So for all of this, regular clinical audits are very important. How am I faring in the way I'm performing the test? How is it being useful to the patient? And how well is it correlating with good patient outcomes? So these are some of the challenges and some of the solutions which I feel are important. Over to you, Dr. Chaitali. Take over. Thank you so much.
Thank you, Dr. Mawa, for such extensive presentation. And thank you, Sanjana, for your brief introduction. So, good evening, everyone. In my talk, I'm highlighting the cascade of diagnostics. As Dr. Mawa has been already gone through the burden of infectious diseases, then emergence, and pathogen and host interactions. So everything has been covered. So in my talk, I'm just highlighting the cascade of diagnostics in infectious diseases by touch basing few of the challenges. So from 2 decades now, please change the slide. Yeah. So from 2 decades, there is a paradigm shift in the diagnosis of infectious diseases, and it was just a. Can you just share the slide? Yes. Yeah. You see now? Yeah, it's Dr. Mawa's slide. Is it? So from last 2 decades, there was a symptomatic based detection from the clinician and the rational use of antibiotic based on the symptoms. Then there are the few technologies which came up like smears or the microscopy, histopathology when it comes to cancer markers. There are few X-ray, and then it has been developed to the solid cultures and liquid cultures. moving up to DST, that is drug susceptibility testing, molecular test, and then to the cutting edge technologies like sequencing. So from symptomatic treatment to the molecular based method or the sequencing based method treatment, what does it affect more? Whether there is a lack of support or it's heavy on the pocket, where the affordability matters. So if in developing countries, if we thought through, this growing shift has made a paradigm changes in the diagnostic of the current cascade. Next slide, please. So there is a shift which I am mentioning about conventional testing to point of care testing nowadays, or the technologies which we are talking about. As there are lots of changes for conventional methods, though they are gold standards nowadays also, what makes this new emerging testing more valuable are the accuracy, the time to give the report to the patient, and also easy on the pockets, that is affordability. Besides this, when it comes to the technical things like sensitivity, specificity, and we have to calculate all these things based on the START guidelines, and then giving them a standard SOPs by using good laboratory practices, better hands to the technicians, which require skilled manpower to it. And trust me, there is lots of things which we need to have in the laboratory side, right? So it's not easy to do any conventional test as compared to any emerging new cutting edge technologies. There is lots of QC involved in the laboratory, right from media preparation till the reporting side, even though it is a qualitative test or it is a quantitative test, whether it's a culture based test or the test which includes the CT values, for example, PCR based test. The previously there is a syndromic approach which gives the classical microbiology. The tests are culture based. The identification is phenotypic based, which based on the lots of biochemical reagents and hell of media needs to prepare in the laboratory. Each of the media is having their own pros and cons when we are preparing it. There is a phenotypic antimicrobial susceptibility testing, which is a disk based, the zone diameter used to measure, and then reporting happens. So if we are changing the technician to that particular day, we can see the variation in the report. Why? Because there is no standardization, there is no validation of the test, and also resistant may become susceptible, your susceptible may become resistant. So there's a huge difference in the reporting when it comes to the classical microbiology or when we are using the conventional techniques. Then comes to the some of the immunocomplex IDs where the test which came with the kits, which includes few of the zone dimensions which has been already there on the strips based method, but again these tests are damn expensive to use in any of the resource limited settings. First thing when classical microbiology comes is time as an issue, because each and every microorganism have its growth, have its growth time. Same slide, previous slide, please. Have its time which takes by the organism to grow, and the first come which first grow. The challenges which we used to face here, the benchmark which we keep for a quality indicators is the contamination rate. Secondly, rate at which organisms are growing or not growing. And then there is a response to the treatment. Because if no organism grows, that means there is no growth detected and report goes without any identification or without any antimicrobial susceptibility testing, where that report is crucial for the clinician to treat the patient. When it comes to molecular biology, we have come up with the identification of specific genes for organism, whether it is a fungus, whether it's a virus. Again, if it is a quantitative, there is a viral load markers which are booming into the labs now. In the COVID, we have seen how labs have been shifted the fundamentals of real-time PCR technology. In some of the molecular methods, yes, culture is necessary. but in some of the molecular methods it's not. So whole focus of molecular biology is now shifted right from culture to directly from the sample. Why it happens? Because there are multiple techniques which are available now for isolation of DNA or RNA directly from the samples, which gives result in very limited detection limits. When it comes to the classical or conventional microbiology, there are tons or loads of a bacteria or the viruses that needs to be there in the sample, and then only we can identify it. But when it comes to the molecular biology or molecular methods, the lower detection limit is high, where we are amplifying this gene or the specific target from an organism. So this is a fast and quick, but we have to be very careful while reporting this kind of a result, because there are lots of data which is coming up with, and if target or your pipeline is not gives credence to that particular organism, then which is the bad guy that you need to identify. There are few superbugs who are more talented than the human R&D, and they may escape from the assigned assay. And most and important thing is, as we are dealing here directly on the nucleic acid, we are not aware whether the organism is live or dead. So viability of the organism is still an issue. And that's the reason, though it's old, though it's classical, though it's conventional, culture have still as a gold standard when it comes to the microbiology, mainly in TB, where follow-up of the patients is based, follow-up the treatment of the patient is based on the cultures. But yes, in this paradigm shift, we have to focus on the current microbiology if we have to give the right report with the same accuracy, and to save the patient's life, we need to adapt all these technologies. When I'm saying when we are shifting from classical microbiology to cutting edge technologies, in that case, there are lots of things generally we look upon. Most is improving time to diagnosis. So there is a paradigm shift. For example, I'm taking example of TB here, where TB is very having a very slow growth rate, where it takes 6 to 8 weeks to grow when it comes to LJ, and when it comes to vegetative, 42 days is a turnaround time to say one culture is negative. But when gene expert endorsed by WHO in 2010, at that time, that week's time has been turned up into 2 hours of time. Just fill it, shut it, and forget it. That's the Hero Honda slogan at that time, if I'm not wrong, which has boomed the technology on the global market, which says that the decentralization of TB diagnostic was at that time is a dream of few of the microbiologists which came into the picture, and each of the lots of gene expert testing technologies labs has been decentralized and opened up, which has been replaced at some time microscopy center also. Improving detection, for example, as I already mentioned about low detection limit, when it comes to TB phenotypic, it requires a lot of time, or there is a lots of dependencies on the technician who are processing the samples, right? It contains lots of tests, right, from decontamination to ice culturing into the midget tube, which requires manual intervention, and finally it goes into the midget instrument, that where automation is happening at the end of the technology, where in molecular methods or the shift, there is a lots of difference, and the time saving possibilities are there. When it comes to the cutting edge technology, it always come with a high throughput or multiplexing. Again, I'm taking another example of a test, that is a line probe assay test. It is having GT48, where you can process all 48 sample in one go. So, which is not happening when we are taking a batches for the culture, as throughput is low. And extended time of a DST has been reduced significantly, and patient can go in on the treatment instead of 1.5 month to 2 months in just 2 to 4 days of a time, 2 hours to 4 days of a time. So this is what we have talked about. So shift from weeks to hours in need of an hour. But there are few methods where we can do decentralizations, but there are few methods where decentralization cannot be done. There is lots of capex involved, there is lots of skill manpower involved, there are lots of validation studies involved, R&D is involved. When I say about validation or standardization of a test, that includes sensitivity, specificity, which Dr. Mohu has touched best about. When we are doing such kind of a test in any of the approved lab, we have to look all these aspects, including diagnostic accuracy. Once it's done, lots of efforts has been used to put into that to get approved by the laboratory stakeholder. When it comes to the international standards, it goes for the College of American Pathologists. We used to get PT samples for there. For this, we have to have SOPs in place. We have to have clinical good laboratory practices. We have training in place. When it comes to NABL or when it comes to other authorities or bodies, where we have to check according to the guidelines, and we have to refer all those guidelines to make this test active in our test menu. So right from validation to bringing the test on test menu, there are lots of hurdles and challenges, right from infrastructure, right from skilled manpower, where when it comes to the infectious diseases, there are lots of occupational health hazard which we have to take care for the employees who are working in on this kind of a sampling. For example, in foreign countries, of course, the person who is working on infectious diseases is paid high than the person who is working on in normal laboratory. So when it comes to the molecular methods, we are looking at a same-day diagnosis. These tests are more accurate and reproducible, less biohazard risk and sensitive as directed directly. It happens on the clinical samples. Feasibility of automation is possible here. When I say feasibility of automation, there are lots of steps which involved in this. For example, extraction. If we are extracting manually, yes, there may be variation on a person to person basis or the reagent or the kit basis. When it comes to automation, there are lots of vendors in the market which is having CE-IVD approved kits for them, where whatever sample type is, who is processing the sample, the sample is going into the instrument and you are getting high throughput or good quality DNA in your hand. Whoever is processing it, doesn't matter. That doesn't matter and going to make any change in the processing or the reporting. And that's the reason we do have high confidence on the reporting. But yes, for this kind of automation also, we need to validate in-house when we are using it for our day-to-day diagnostics methods or when we are issuing report to the patient. Also, it's able to detect mutation associated with lower levels of a phenotypic resistance. For example, in phenotypic methods, if we are getting a result stating that this is resistant or susceptible, but what if that mutation is not associated with resistant? In that case, that lucidity, you will receive it from a molecular methods, and that's the reason. Though it's challenging to incorporate such kind of a test into the day-to-day laboratory algorithm, I'll facilitate to take this decision based on the diagnostic accuracy method, based on the guidelines, based on the SOPs as the requirement of the stakeholders, whether it's NABL or CAP, we need to go for it. Next, please. So, leading use of molecular methods, in my sense, it is a non-culture agents. It is fastidious or so slow-growing organism. We can use it, for example, in TB. In highly infectious agents, dangerous to culture, as we all see in the waves of COVID, right? In that, when it comes to viral, we cannot culture it. There are no labs except few or two handful of labs. In that case, what entire globe did was PCR based on the nucleic acid amplification. So highly infectious agents which cannot be cultured can be identified and can be treated and cured by this kind of methods. In COVID also, in viral markers are also, when it comes to qualitative detection or quantitative detection, there is a standard guidelines given by START. So these guidelines gives us the information. There is a booklet available online where you can refer, and whatever challenges which we can face for validating this test and what kind of a result we should get and when you can start this test in-house, those all have been mentioned in that kind of guidelines. Again, resistant testing marker is the better and the best way nowadays by use of molecular methods. Early detection of a tumor markers and cancer biomarkers, few of the biomarkers in infectious diseases and genotyping. So this is from my end. For end, I'm giving you the timeline for DB diagnostics in a landscape. This is just an example how it has been evolved in just 6 to 7 years of a time, right from culture methods to whole genome sequencing by this time. Why we are thinking of all these things, though there is a challenges, though there are the cutting edge technologies in the pipeline, though there are there are the SDGs which says that there should be a current cascade in the landscape of a TB diagnostic or any of the diagnostic, whether it's the antimicrobial stewardship or AMR, which is booming in the world now. So why we are going and running behind all these things is just for a syndromic approach, one key technology, that newest data which looks into variant of a human genome in genes that are involved in drug metabolism. So in the pipeline, pharmacokinetics, pharmacogenomics, these are the things which are upcoming, and these are the extremely helpful, that which we can, being a laboratory person, can help clinician to initiate the therapy prior in order to choose best and most appropriate therapy for the patient, which is fastidious, for slow growing organism, for the organism which are non-cultures. Thank you.
Hello, everyone. I'm sorry for that little technical glitch. Thank you very much, Dr. Mahua and Dr. Chetali, for your wonderful talks and for giving us such detailed information on our webinar topic today. Very helpful to us. In the interest of time, we will try to answer each of these questions individually. And we thank you, everyone. And we close the session for today. Thank you very much.